Hello everyone, welcome to Module 6, Parenteral Nutrition, Monitoring and Complications. So this module includes components from Chapters 7, 8, 9, and 10 from the Aspen Parenteral Nutrition Handbook. I definitely encourage you guys to review these chapters as they will provide an excellent supplement to what I'm going to present here. Here's your handy dandy nutrition toolbox slide. So as part of monitoring nutrition therapy, we look for any and all opportunities to transition to another therapy. I added the arrow here because patients can be transitioned from PN directly to an oral diet, especially if they are free living, as you will see more of in the home nutrition support module. I know y'all are probably sick of seeing this slide as well, but it just serves as your once per module reminder that combination therapy works and there's no reason not to use it if it's necessary to transition between therapies. So once again, looking at this route of administration algorithm here, we're focusing on the parenteral side of things. And so as you look at this, think of key areas where we would monitor PN therapy. So access, how long do we need this therapy? Are we just initiating PN until patient they have an ileus and we're awaiting return of bowel function? Or maybe we're just initiating PN until enteral access can be established by IR in the next couple of days. In that case, PPN might be appropriate. Or let's say patient has an EC fistula and they're going to require nutrition optimization prior to surgery to take down the fistula. In that case, we're going to be looking at obtaining central access and doing CPN. We want to look at tolerance of solution, so hyperglycemia. Readiness to transition. Has GI function returned? Is oral intake indicated? We want to look at the appropriateness of continued feeding. Is it appropriate to continue PN or can we transition to EN? Or maybe the patient has a change in condition. They crash to the ICU. Are they stable enough to continue feeding? All those things I want you to try and think about. Remember that it is always better to prevent than to treat. That is why proper monitoring is so important. So first things first, we want to choose PN cautiously. It's expensive, it comes with an increased risk, and it's really designed as a last resort to therapy. Nursing will monitor the catheter site, but refer to labs and look for signs of infection. While it's a minor procedure to change a peripheral line, it is a little bit bigger deal to have to remove a central or tunnel line. But if there's an infection, you may not have to have another option and the line will have to be pulled. Most diseases, especially in the critically ill population, do not respond well to overfeeding, and some become worse if you overfeed. So we want to try and maintain glycemic control, less than 140 to 180 milligrams per deciliter. We want to limit lipids to 1 gram per kilogram for most patients, especially those that are critically ill. We can use 2.5 grams per kilogram in other patients if it's indicated. We want to try and keep our dextrose infusion, our GIR, at 4 to 5 carbohydrates per kilogram per minute in stable adult patients, and then less than 4 in critically ill patients. And I mentioned it previous modules, but the exception here would be long-term patients who are cycled, non-diabetic. We keep their GIR less than 7. We want to make sure that we adjust protein based on metabolic demand and organ function, and make sure your bag is balanced as far as macronutrients goes. In addition, tolerance to PN is less if you overfeed. So monitor your labs to be aware for intolerance and be proactive. Make changes before you have to stop lipids. Constant monitoring of fluid and electrolytes are important. Small additions or deletions in PN can help prevent acidosis, alkalosis, refeeding syndrome, dehydration, overhydration, etc. Always make sure that your patient is receiving the appropriate vitamins and minerals in their PN. Again, you can avoid things like Wernicke-Korsakoff syndrome, kidney issues, etc. Trace elements are usually given daily, but you may have to limit them to 3 times per week in patients with liver dysfunction where their total bilirubin is greater than 4, or if they have renal dysfunction with a creatinine clearance less than 30 who are not on dialysis. The book actually doesn't have a lot of information on monitoring of PN, so we're going to go through a few things here. When you think about what to monitor in PN, consider the PN mixture itself, the dextrose, amino acids, the lipids, the disease, injury, or state, and conditions that affect serum electrolytes, lipid levels, and other laboratory parameters. Monitoring weight will most reflect monitoring of fluid status. This may be challenging in the hospital when you have additional fluid that's being provided outside of the PN bag and medications. When you encounter low levels of electrolytes that need repletion, it's best to do this outside of the PN. PN infuses over several, up to 24 hours, and acute changes need to be made in a timely manner. So sometimes in the hospital setting, doctors, they're hesitant to replete electrolytes because the patient is on TPN. You can still adjust based on trends, but it is not the job of the TPN to replete electrolytes. It's okay to give outside. We want to be sure that we're evaluating for vitamin and mineral deficiencies. The nutrition focused physical exam and dietary history are really important in identifying risk. If a deficiency is suspected, you can order a lab test to confirm. Certain vitamins and minerals can be added to the TPN in addition to the standard multivitamin and trace elements packets. It's rare that you're going to come across deficiencies, but remember certain patient populations that are at a greater risk that include malabsorptive bariatric surgery, such as your Roux-en-Y's, your duodenal switches, any kind of malabsorptive condition, and then long-term TPN patients who don't eat anything by mouth. Vitamins and minerals should be checked at least 1 to 2 times per year in chronic home TPN patients. Another thing to think about, how active is your patient? You may need to address macronutrients based on activity. For patients who are going home on TPN, you need to cycle the infusion as tolerated and able so that your patient can have better quality of life and freedom to do the things that they want and need to do. Catheter site will be monitored by nursing or home health in the outpatient setting, and the patient to some extent in the outpatient setting. It's important that before you reorder the TPN for the next day that you verify with nursing that the catheter is working and flushing properly and that there aren't any issues. We want to avoid wasting TPN bags, especially for something as simple as the line isn't working properly. And then remember that part of monitoring is always evaluating when and if the patient can transition to EN or oral feedings. If the gut works, use it. Like I just said, when and if appropriate, PN patients should be transitioned to the next therapy, whether it's EN or oral intake. In some cases, we do have to start with EN, then transition to oral intake if oral intake is inadequate with a functional GI tract. Otherwise, some patients might not have to use EN. They might be able to go straight from PN to oral intake. Always decrease one method while increasing the other so that our patients are meeting their needs. This table gives you a nice guide on which lab should be utilized to properly monitor the patient and help prevent complications. Everything with the exception of nitrogen balance you should get as a baseline whenever you start a patient on PN. At minimum, you need a basic or comprehensive metabolic panel with phosphorus and magnesium daily until the PN formulation is stable. Triglycerides should be monitored at the start of therapy and then weekly while in the hospital setting. Long-term stable PN patients get their labs drawn, they can get them drawn as little as once per month. Other monitoring parameters, we have the catheter site, which we briefly discussed earlier. That's done daily and it's going to be done by nursing. We want to make sure that we're monitoring ins and outs. So if your patient has a high output fistula or an ostomy, then volume may need to be adjusted in the TPN. Activity levels, we want to keep an eye on those if we need to adjust macronutrients. We can obtain blood cultures if a line infection is suspected. And then also be mindful of any drug nutrient interactions. Your pharmacist is a great resource here. Although PN is a great therapy, there can be contraindications to starting. This table just provides basically kind of some warning areas to be aware of before we start PN. Basically, the gist here is that severe abnormalities need to be corrected before we start PN. When monitoring for complications, we want to recognize which patients may be at risk for refeeding syndrome, especially the malnourished ones. Daily labs are super important until the PN is stable. And these patients may take longer to get to that goal dextrose, get to that goal stable formulation. Liver function tests, those are usually included in your comprehensive metabolic panel or hepatic function panel, and they should be monitored at least weekly in the hospital setting while receiving PN. More frequent monitoring may be required if there are significant abnormalities. Patients who have liver dysfunction, you're going to want to try and cycle them sooner rather than later so that we can give the liver a break from metabolizing the TPN. Looking at people with diabetes or glucose intolerance, SNS here refers to specialized nutrition support, and that term comes from the Aspen Board of Directors. But SNS should be initiated with a low dextrose infusion rate and the blood glucose monitored closely. Usually in the hospital, blood glucose is going to be monitored at least every 4 to 6 hours using finger sticks. And then for those that are receiving insulin, we definitely want to monitor glucose frequently upon initiation of specialized nutrition support and then upon any change in the insulin dose and until measurements are stable. We're going to talk for a second about stability and compatibility. This complication of PN really should be managed in the pharmacy. However, a bag of PN could come to the ICU or the floor with degradation that has not been noted. That's why each and every PN bag should be inspected prior to using it. Although stability and compatibility are terms that are often used interchangeably, a distinction exists between the two terms in reference to parenteral admixtures. So stability of PN formulation refers to the degradation of nutritional components that changes the original characteristics. A classic example is going to be the Maillard reaction. So that occurs between IV dextrose and amino acids such as lysine, which results in a brownish discoloration of the final formulation. Stability may also refer to the ability of PN additives, including medications, to maintain their chemical integrity and their pharmacological activity in the mixture. In contrast, compatibility issues with PN formulations that generally involves the formulation of precipitates. So these precipitates may be solid, such as crystalline matter, or liquid, such as phase separation of oil and water in a total nutrient admixture. For compounding complications, you could have particulate contamination, which is going to be your solid precipitates, and phase separation, which is creaming and cracking. For your solid precipitates, that's going to come from calcium and phosphorus. So it's seen more in neonates due to the high amount of calcium and phosphorus that is usually required by these patients, but it can also occur in patients who are requiring large amounts of calcium and phosphorus who also require a fluid restriction. And so whenever you include a large amount of calcium and phosphorus, it might be better to do so in a 2-in-1 bag because a 3-in-1 solution limits your ability to see precipitates. So whenever, most everything's done electronically now, right? So whenever you order your TPN bag for the day, you're going to have a curve, and it's a calcium phosphorus solubility curve. And each curve represents the maximum solubility of the calcium and phosphate for a specific amino acid concentration. And so you always have to keep your levels under the curve, and this will make more sense when you do it, but keep it under the curve so that we're trying to prevent the formation of these solid precipitates, because as you can imagine, anything solid that goes through an IV could end up being fatal. Erroneous final concentrations are avoided by following the national manufacturing standards, triple checking PN bags, using refractometry, and careful review of translated orders with a referral source. So that's really going to be done in the pharmacy. Hot weather. You actually need to be sure that your patient's refrigerator is keeping the PN solutions cold. So that would obviously go for the home setting, and then even in the hospital or facility setting, making sure refrigerators are adequately maintained and temperature logs are accurate. The home infusion company, they may actually need to send the patient a small refrigerator for PN storage to ensure that the emulsion does not crack. In the winter, PN should not be hung next to any kind of heating unit either. Talking a little bit more about calcium and phosphate solubility. So those that have an increased risk of calcium phosphate precipitation, obviously it's going to be increased calcium and increased phosphate concentrations, using calcium chloride salt versus a calcium gluconate, and then increased temperature of the PN admixture. But factors that increase calcium phosphate solubility include using an increased amino acid concentration, an increased dextrose concentration, and a lower pH of the PN admixture. So for neonates, you can actually add L-cysteine, which is a semi-essential amino acid in premature infants, and it lowers the acidity and helps decrease the pH. Unfortunately, though, an acidic mixture it destabilizes the lipid emulsion, so therefore in neonates we use a 2-in-1 delivery method instead of a 3-in-1. And then when it comes to adults, you're most often going to run into calcium phos curve issues with patients who need volume restricted PN but also have high phosphorus requirements. So increasing the volume of the TPN will also help increase the calcium phos curve. Here's a list of medications that are compatible with both 2-in-1 and 3-in-1 solutions. These medications are assumed to be given via a Y site, and it's also assumed that there are no other medications that are in the PN solution, and that these medications are given one at a time. Before you put any kind of medication in a TPN bag, always check with your pharmacist and the physician. This list, it does come from the 2012 Nutrition Support Core Curriculum. I need to look because there might be a more up-to-date list, but remember, the PN bag is not for drug delivery. The only things that we're really putting in the TPN bag are going to be H2 receptor blockers or a proton pump inhibitor, so your famotidine, or insulin. And those are really the only two things in practice that we're adding to PN bags. These other drugs here, they are compatible and can be given with the TPN, but we're not putting dobutamine, we're not putting vancomycin into a TPN bag. So, other than PPI or insulin, do not add drugs to the TPN. Here's a list of some incompatible drugs. So the list on the left is for drugs whose compatibility is either unknown or there's insufficient data to determine compatibility. And then on the right-hand side, you have a few medications, usually ones that are fat soluble, that are compatible with a 3-in-1 solution, but not a 2-in-1 solution. And then you have medications that are only compatible with a 2-in-1 solution. So for instance, iron dextran, it may be administered in a 2-in-1 TPN because the lipid formulations are disrupted by iron. So it's not recommended for addition to 3-in-1 TPN solutions because iron clogs the TPN filter with lipids. So if iron supplementation is necessary, it can be added to a lipid-free TPN or preferably given separately in a mini bag or intramuscular injection by the physician. There is a risk of anaphylaxis. A test dose should be given in a controlled environment with a physician present, and then we only supplement with documented deficiency. In your book, tables 10.2, 10.3, 10.4, and 10.5 have a bit longer and more extensive list of compatible and incompatible drugs. Now we're going to start transitioning into potential complications of PN. So hospitalized patients, they often receive short-term PN. Complications can be minimized with effective management. So managing fluid and electrolytes, making sure we have good glycemic control. For long-term TPN patients, complications are going to be metabolic bone disease and hepatic dysfunction. And then sepsis can actually be a problem for both short-term and long-term PN patients. And good patient education, good catheter care, they can help prevent that complication. Potential complications, we could be dealing with fluid issues, so acid-base disorders, electrolyte imbalances, calcium phosphorus stability. We could be dealing with refeeding syndrome, carbohydrate issues, so hyper or hypoglycemia. If we have protein issues, we could have azotemia. For lipids, complication could be hypertriglyceridemia, essential fatty acid deficiency, or hepatobiliary complications such as fatty liver and cholestasis. Metabolic bone disease is a concern for those long-term patients. Vascular access sepsis, other issues with the catheters, and overfeeding. So for fluid balance, we could have a fluid excess, so critically ill patients and those with cardiac, renal, In hepatic failure, they may require fluid restrictions. We may need to restrict total calories in order to reduce the total volume that's given. We want to use the most concentrated source of PN components, so 70% dextrose, 20% lipids, and then 15% amino acids as opposed to 10% amino acids. Know that PPN may be contraindicated because that requires more volume because of the osmolarity constraints. For patients that are at a fluid deficit, so those could be patients that have excessive losses and they may require the addition of sterile water to the PN. We want to make sure that we're providing the required fluid volume in the PN whenever we're able to. And then we want to monitor those ins and outs, weight, serum sodium, their BUN, hematocrit, skin turgor, pulse rate, BP, urine specific gravity. Don't forget to account for all of the fluids that are being given outside of the PN. This is especially true in the ICU setting. As you can see here, many patients look like this in the ICU where they have tons of pumps, tons of things going at the same time. Electrolytes. So electrolytes in the PN, they should be given at a stable dose with intermittent requirements for supplementation that's given outside of the PN. Hypokalemia, it may be due to excessive GI losses, metabolic alkalosis, and refeeding. Hyperkalemia may be due to renal failure, metabolic acidosis, potassium administration, or hyperglycemia. And sodium levels often reflect the fluid distribution versus actual sodium status. Believe it or not, magnesium is also important in the regulation of intracellular potassium. Hypomagnesemia may result in refractory hypokalemia, and this is likely due to the accelerated renal potassium loss or some impairment of the sodium-potassium pump activity. When hypokalemia and hypomagnesemia coexist, the magnesium deficiency has to be corrected first to facilitate the correction of that hypokalemia. So you have to replete magnesium before you can replete that potassium. Talking about calcium here, hypocalcemia, it occurs as the result of either decreased calcium intake and or an increased calcium urinary excretion. So you have that excessive phosphorus salts, low serum albumin, or if you have inadequate calcium in the PN. Treatment would be decrease the phosphorus, and then you can check an ionized calcium lab and or calculate the corrected calcium. If it's normal, then no intervention is going to be necessary. And then increase the calcium if the amount is inadequate. For hypercalcemia, cause is going to be excessive calcium in the PN. Treatment is going to be to decrease the calcium that's in the PN, decrease amino acids if that's the cause, and then make sure that we're providing adequate hydration. Here are some basic slides on acid-base balance. Chapter 7 in your handbooks will provide a great support to this. Basically, we want to make sure that we're balancing the chloride and the acetate in the PN to help maintain and achieve equilibrium. Your standard acetate to chloride ratio is 1:1. And then we want to, this table on the side, it gives you just a quick way to determine if the patient has acidosis or alkalosis and whether it's respiratory versus metabolic. Note that in the TPN, if your patient has respiratory acidosis or respiratory alkalosis, nothing we really do in the TPN is going to help that. That's respiratory driven. That's going to be on the physicians to really fix that. But we want to increase the proportion of chloride with metabolic alkalosis and increase the proportion of acetate with metabolic acidosis. And then always consider the chloride and acetate content of amino acids. So whichever amino acids that your facility uses, make sure you look at the pamphlet and see what those ratios are. So if you have an elevated serum bicarbonate, it's one of the markers of metabolic alkalosis. In metabolic alkalosis, it can be caused by nasogastric suctioning, volume depletion, and diuretic use. In a PN patient, excess use of acetate, which is metabolized to bicarb, it may precipitate a metabolic alkalosis. Excess chloride, diarrhea, and acute renal failure are common causes of metabolic acidosis. There is an article on Blackboard. It's the acid-base tutorial from JPen. It offers a really good explanation on a subject that most people find difficult. At minimum, you should be able to diagnose if a patient is in metabolic acidosis or alkalosis, as well as respiratory. The basic treatment for metabolic acidosis is to increase the acetate in PN. And then for metabolic alkalosis, we want to increase the chloride. Of course, in doing so, you're going to change the ratio of chloride to acetate. And then, for example, if a patient is in acidosis, you need to decrease the chloride to acetate ratio. And then, I said it earlier, I'll say it again, note that nutrition is not going to fix respiratory acidosis or respiratory alkalosis. Causes of metabolic acidosis include hyperchloremia or too much chloride, which can lead to hydrochloric acid formation. Too much carbohydrate, especially when a lot is being metabolized by glycolysis, can lead to lactic acid formation. And then there's an increased risk in pulmonary disease, renal failure, diabetes, particularly diabetic ketoacidosis, certain cancers, and then in the infant and neonate population. So for treatment, to decrease the risk of hyperchloremia, we want to add lactate, acetate, or phosphate forms of minerals and amino acids. Or we can substitute basic ingredients for acidic ones. So example, we can put sodium acetate in the TPN instead of sodium chloride. And then we want to avoid excess infusion rate or amount of energy nutrients. Now we're going to start talking about refeeding syndrome. So patients at risk are going to be those that have chronic malnutrition or patients who have been without oral, enteral, or parenteral nutrition for anywhere from 7 to 14 days, and then your acutely malnourished patients as well. Indicators, the hallmark are hypophosphatemia, hypokalemia, hypomagnesemia, and then acute respiratory failure, hypotension, and tachycardia are also indicators. So we want to make sure we're monitoring serum phosphorus, magnesium, potassium, glucose, and sodium. Interventions, first of all, prevention is key. We want to replete electrolyte disorders first, so any crazy electrolyte derangements, we want to try our best to replete those, correct those before we start PN. And then when we do start TPN, we can start at less than or equal to 50% of the carbohydrate dextrose caloric goal, and then we'll gradually increase over time. You may require repletion of thiamine and phosphorus prior to the initiation of nutrition support, and then careful electrolyte monitoring and replacement are critical. So basically what happens in refeeding syndrome, the sudden administration of carbohydrate, it exerts a considerable strain on the respiratory system, whose musculature may well be atrophied already due to starvation. So there's an increase in carbon dioxide production and O2 oxygen consumption, and then there's an increase in your respiratory quotient. The consequence of this is an increase in minute ventilation, which may cause dyspnea and tachypnea. Phosphorus falls with refeeding due to a shift of phosphate from the extracellular to the intracellular compartments due to the demand for this ion for synthesis of phosphorylated compounds. This can result in respiratory failure, cardiac arrhythmias, rhabdomyolysis, seizures, and coma. And then refeeding syndrome, it usually results from intracellular electrolyte shift, often a result from too many calories when beginning feeding. You'll also see reduced serum levels of magnesium, potassium, and phosphorus. Phosphorus, you have that profound drop in phosphorus. That is the hallmark of refeeding syndrome. Hyperglycemia and hyperinsulinemia, you'll see interstitial fluid retention due to a sodium retention, and then you have pulmonary edema, heart failure, and dysrhythmias. And then eventually you could even have cardiac decompensation and arrest. So refeeding syndrome is no joke. Everybody on the hospital should be on the lookout for it, but it's absolutely crucial that we prevent it before it happens. So kind of just a recap, we want to monitor and supplement electrolytes, vitamins, and minerals prior to and during infusion of PN until levels stabilize. Then we want to initiate feedings with 15 to 20 calories per kilogram or 1,000 calories per day, or maybe even less depending on the patient, and 1.2 to 1.5 grams of protein per kilogram per day. For custom solutions, I usually recommend initiating with 100 grams of dextrose or 50% of the gold dextrose. Hyperglycemia, that's going to be probably the most common complication of PN that you're going to see. The risk is increased by a high glucose infusion rate, impaired insulin secretion or insulin resistance, patients with diabetes mellitus, stress and trauma, sepsis, infection, those with pancreatitis, and then certain medications like steroids, and then those with chromium deficiency. For preventing hyperglycemia, we want to watch our glucose infusion rate. For most patients, remember not to exceed 5 milligrams per kilogram per minute, but we want to try and keep it less than or equal to 4 for those with diabetes and those with critical illness. Then we're going to obviously want to measure blood glucose, your eyes, nose, and plasma sodium often. And then remember the asterisk here is just for stable home TPN patients who are not diabetic. You can push that GIR up to 7 as tolerated. And then remember, this is for adults. Infant GIRs are often the teens. So treatment, monitor our blood glucose goal is less than 140 to 180 milligrams per deciliter per the Aspen guidelines. We want to give insulin so we can manage outside or add it to the TPN as needed. We can try and give less carbohydrates and more fat calories if possible. As a final check of nutrients, make sure that you're calculating the percentage of each macronutrient for calories. In many patients, you can still give, 3, push the GIR to 3, and you can be administering 55% of carbohydrates. So look deeper into the PN prescription, calculate the percentage of calories. Carbohydrates really should not exceed 50% of calories in most situations. But if your patient is diabetic, if they're on a ventilator, or if they're critically ill, otherwise try to stay between 40 and 50% of carbohydrates of total calories. And then for long-term patients, make sure that we're giving them those trace elements and they're not at risk for a chromium deficiency. So for achieving glycemic control in PN, for patients who were not previously on insulin, we want to monitor blood glucose levels prior to initiating PN. When therapy is initiated, we monitor blood glucose every 4 to 6 hours, and then we use sliding scale, or if you're in the if they're critically ill in the ICU, we can use an insulin drip as needed. And then we want to try and add a portion, 1/2 to 2/3 of the previous day's insulin to the PN to maintain blood glucose levels. Now, if your patient was previously on insulin, we can determine the amount of insulin that was needed prior to their illness, and then we can provide a portion of the daily insulin needs in the first bag of PN along with sliding scale or the insulin drip in the ICU to maintain glucose levels. Generally, insulin needs will increase while you're on PN. So the standard monitoring for the diabetic patient is we want glucose checks in the diabetic patient on PN every 2 to 6 hours, depending on whatever your facility protocol is, their insulin requirements, and their general clinical condition. Next, diabetic patients that are receiving PN, they should have a maximum glucose infusion rate of 4 milligrams per kilogram per minute. And then we want to start anywhere from 100 to 150 grams of dextrose a day to avoid hyperglycemia and refeeding. The estimated initial amount of insulin to add to PN for a diabetic is anywhere from 0.05 to 0.1 units of insulin per gram of dextrose. And then we can increase that daily to achieve glycemic goals by adding up to 2/3 of the previous day's sliding scale insulin into the TPN. The increase in blood glucose levels that are seen in diabetic and critically ill patients is usually associated with a higher frequency of infection. The intense counterregulatory hormone and cytokine responses to severe disease and the excessive administration of glucose, which is usually as PN, they could contribute to hyperglycemia and the associated infectious complications. So when we add regular insulin to the PN, the availability is usually anywhere from 53 to 100%. Usually a good rule of thumb is that 10 units sticks to the inside of the bag. So if you're starting out with a small amount of insulin and you don't see much improvement, that could be why. Also, the regular insulin, it has a short half-life and the delivery coincides with nutrient infusion. So you're just covering the dextrose that's in the TPN. And so that shouldn't make the patient hypoglycemic once the TPN stops. And then by the same token, patients, they also might need a basal insulin outside the TPN too. Causes of hypoglycemia, that could be excess insulin dose or an abrupt cessation of PN. Treatment would be a 10% dextrose infusion, 25 grams. We can stop or adjust the insulin dosage. A 1 to 2 taper down of the infusion or half of the infusion rate, that could be helpful. And then if you have to discontinue PN abruptly, you can start D10W for 2 hours. Readjust your insulin downward prior to ceasing PN, and this is typically done with the assistance from pharmacist or endocrinology. The complication of azotemia, that's increased risk in patients who are greater than 65 years of age, if they have a protein infusion at 2 grams per kilogram per day, if they have hepatic or renal disease, or those with stress and trauma. Prevention, we want to monitor BUN and creatinine and then adjust the amino acids if necessary. We want to avoid overfeeding, particularly the protein, and then we want to make sure that we're providing adequate fluid. Treatment would be decreasing the amount of amino acids that we provide. We can do dialysis if necessary, and then once again, adequate hydration. If the patient has hepatic encephalopathy, hyperammonemia, or hepatic failure present, the use of high branch chain and low aromatic amino acids has inconsistent results. Basically, what it all comes down to is we want to limit the amount of protein we administer, but also be careful to avoid malnutrition. So risk for hyperlipidemia is increased with a rapid infusion of PN lipid loads, which would be greater than 110 grams per kilogram per hour. Those that are on propofol infusion, and then any kind of dextrose overfeeding or overall just calorie overfeeding. And then hyperlipidemia, it results in an impaired immune response, altered pulmonary hemodynamics, and an increased risk of pancreatitis. Treatment, we want to decrease the soy oil injectable lipid emulsion to less than or equal to 30% of total calories or 1 gram per kilogram per day, and we can provide them over a cycled period of 8 to 16 hours per day via a 2-in-1. So using a 2-in-1 solution, it allows the lipids to be administered over a shorter time than the dextrose and amino acids, and that allows the lipids to clear the bloodstream. And then we can also try an alternative lipid emulsion that has less soy, so we can use SMOF lipid, Omegaven, Nutrilipid, or Clinolipid. And then if triglycerides are elevated, decrease the IV lipids to an amount to prevent essential fatty acid deficiency. So 250 mLs of 20% lipid twice weekly in monitor. Some patients, they will just have more trouble metabolizing IV lipids than others. Make sure we're monitoring the triglyceride levels and stop them if they begin to rise. You do not need to wait until the triglyceride is 400 to stop the lipids. Usually after 24 hours, the lipids have cleared the system and you can resume the lipids. Restart slowly and check the triglyceride levels to be sure. And then always refer to the manufacturer guidelines if you're using these alternative lipids for what amount is needed to prevent essential fatty acid deficiency. Speaking of essential fatty acid deficiency, symptoms can develop in as little as 1 to 3 weeks on lipid-free PN, especially in patients that already have a low body fat amount. Signs and symptoms are dermatitis, alopecia, which is hair loss, immune dysfunction, fatty liver, low plasma linoleic acid, and then a triene to tetraene ratio of greater than 0.2. Treatment, like everything else we've talked about so far, it's easier to prevent than to treat, but we want to give oral or injectable lipid emulsion fat to prevent essential fatty acid deficiency. And we want to give at least 250 mLs of a 20% injectable lipid emulsion, soy-based, twice per week. And I think I said it just a second ago, but I'll say it again here. Remember that the non-soy based lipids may have different amounts that are recommended to prevent EFAD, and make sure you refer to those manufacturer recommendations. But we want to stop dextrose infusion for 24 hours to help decrease insulin and promote mobilization of fatty acids from the adipose tissue. And then we might need to do a topical application of oil, and it can be given as treatment to help alleviate symptoms. Here are some situations in which we might want to limit or avoid IV lipids. Patients that have pancreatitis with significantly elevated plasma triglycerides, those that have severe egg allergies. For hypertriglyceridemia, our criteria is going to be hold lipids if triglycerides are greater than 400 in a 3-in-1 solution, or if they're greater than 250 when we use a 2-in-1 delivery. Want to limit in lipid nephrosis, and then of course we want to avoid if the patient has any kind of allergic type reaction to the product. And then we can also limit or avoid IV lipids in patients with severe liver or pulmonary disease in certain cases. So depending on the severity of the issue, often decreasing the infusion rate of the lipids will correct the issue, or even just holding the lipids for a few hours. If the issue continues, hold the lipids until it resolves. And then when we restart lipids, we can begin at a slow rate on a cyclic regimen to avoid recurring problems. So we restart lipids in a 2-in-1 solution, and then we infuse the lipids for 10 to 16 hours once triglycerides are less than that 250 milligrams per deciliter using that 2-in-1 solution. Consider one of the newer injectable lipid emulsions if it's available to you, which have less soy. And then this will just allow the liver to clear the lipids through the system. And then when we restart lipids, we can do so at a less amount and titrate up to goal. Keep monitoring triglycerides to ensure that lipids are being metabolized correctly, and always remember to keep lipids at 30% of total calories or less. Moving into GI complications, there are 3 basic types of hepatobiliary disorders that are associated with PN. That can be steatosis, cholestasis, and then gallbladder sludging or gallbladder stones. Hepatic steatosis, it generally occurs in adults, and it presents with mild elevations in your aminotransferases, your serum alkaline phosphatase, and the bilirubin concentrations. This particular type of hepatobiliary disorder is most often a complication of overfeeding. So we've talked about before how important it is not to overfeed your patients. Cholestasis, occurring primarily in children, is characterized by the impaired biliary secretion. So you're going to have elevated conjugated bilirubin levels. They're the most common laboratory manifestation in this population. And then gallbladder sludging or stones is thought to result from the lack of enteral stimulation in the GI tract, and it occurs with long-term PN use. Treatment, hepatic dysfunction can result from any kind of long-term TPN administration. Conversion to a cyclic administration, it allows the body to oxidize fat and it gives the liver a break. And so that results in lower insulin levels as well as improved liver enzymes. It's also important to avoid excess calories and excess calorie administration that will result in steatosis. GI atrophy, that can occur with prolonged bowel rest. Anytime we can stimulate the GI tract with pleasure feeds or trophic feeds, the better. And then with gastric hyperacidity, we want to make sure we treat with H2 receptor antagonist or proton pump inhibitors. I've included an extra slide here over cholestasis and just with a few extra details. Cholestasis, it may be precipitated by hepatic disease, GI disease, or overfeeding. As with everything that we've talked about so far, the overreaching theme here is prevention is always the key. Watch your labs closely, especially in those patients who are at risk. Omegaven has actually been shown to reverse cholestasis in pediatric patients, but not adults. Here is just a summary of all of the reasons that we do not want to overfeed our patients. So consequences of overfeeding, like we said, respiratory issues. Overfeeding carbohydrate can cause excess CO2 production and respiratory distress, and that can result in hypercapnia and make weaning off the ventilator difficult. Fat overload syndrome But the recommended maximum amount for IV lipids is 1 gram of lipid per kilogram per day. We want to infuse IV lipids slowly, and then we can do it in a cyclic pattern from 10 to 16 hours, or even 24 hours is still fine. Hepatic steatosis, patients that are receiving a high amount of carbohydrates or that are very low in fat in the PN are also at risk. Hyperglycemia, it increases the risk of infection. Our glucose infusion rate, remember, it should not exceed 5 in most cases, or 4 for diabetics and critically ill patients. Hypertonic dehydration, it can be caused by a high protein formula with inadequate fluid provision. Hypertriglyceridemia, infusion of high PN lipid loads and or propofol could cause this, and it increases the risk of sepsis. So we want to decrease lipids to an amount to prevent essential fatty acid deficiency and always be monitoring. For azotemia, it's related to a high infusion of amino acids and especially at risk with inadequate fluid. And then metabolic acidosis, patients who are receiving low ratios of energy to nitrogen are at risk, and acidosis can cause muscle catabolism and negative nitrogen balance. And then lastly, that refeeding syndrome. Remember that it's common in malnourished patients or those with prolonged MPO status. And then prior to initiating feeding, we want to make sure we correct any significant electrolyte abnormalities. And then when we do start the feeding, we want to advance gradually and monitor those potassium, phosphorus, and magnesium labs closely. Metabolic bone disease, it can be seen in patients who are on chronic PN infusion, so greater than 3 months. The real cause is mostly unknown, but we do know that an important contributor to metabolic bone disease is a negative calcium balance. So hypocalcemia, it occurs as a result of a decreased calcium intake and or an increased calcium urinary excretion. So factors that would cause hypercalciuria, which is that increased calcium urinary excretion, it includes excessive calcium and inadequate phosphorus supplementation, excessive protein in PN solutions, cyclic PN infusions, and chronic metabolic acidosis. The most appropriate intervention for this patient is going to be protein reduction. So ideally, protein doses for long-term PN provision, it really shouldn't exceed 1.5 grams per kilogram per day. Although the exact mechanism of protein-induced hypercalciuria is unknown, it could be related to an increased glomerular filtration rate, or GFR, or increased excretion of sulfates, ammonia, and urinary titratable acidity that decreases renal calcium reabsorption. So symptoms, we're going to have bone demineralization, and it can also cause severe periarticular, which is the area that surrounds a joint, pain there, and then lower extremity and back pain as well. And then for treatment, really the only known treatment is to temporarily or permanently discontinue the PN. Here are some special considerations when you're dosing TPN. For patients with renal failure, you may need to decrease the magnesium, phosphorus, potassium, amino acids, and fluid based on their clinical condition. Administration of vitamin A in patients with renal failure can lead to pancreatitis, so be careful with the vitamins. And again, limit the vitamin supplementations in patients with renal failure just to vitamin C and the B vitamins if you're able. And then you may need to decrease trace elements to 3 times per week in patients that have a creatinine clearance less than 30 who are not on dialysis. If they're on dialysis, you can proceed with daily trace elements. In patients with cardiac failure, you may need to decrease the sodium in the fluid content of the PN solutions. And then those for short bowel or have ileostomies, you may need to increase the sodium, potassium, magnesium, chloride, acetate, zinc, calcium, and fluid. In addition to all of the metabolic complications of PN, we could also have complications with the catheters themselves. So that includes occlusions, catheter-related infections, and even sepsis. So for occlusions, typically nursing is the one that handles the catheter sites. We want to make sure that they're adequately flushing the tube with all medications. And then if a medication can be administered, by a route other than the PN, always use that alternative route. Infection and sepsis are related to central lines. Phlebitis and thrombosis may occur in a peripheral IV site, but these are typically not used for nutrition support lasting more than a few days. But infections with organisms such as Pseudomonas, Staphylococcus, Streptococcus, Klebsiella, and Candida albicans, they'll all need to be treated with antibiotics. And so you have to culture the site, and it may take up to 48 hours to get lab results back on which bacteria the catheter is infected with. And at that point, antibiotics can be tapered to specific ones. Tunnel catheters that are placed through the subcutaneous fat layer usually have a less incidence of infection because fat kind of has an antibacterial, antimicrobial effect. Note that PICC lines, they cannot be placed for initiation of TPN if the patient has pending blood cultures. So you're going to have to wait for those blood cultures to clear before we can place a central line. Double and triple lumen catheters like subclavians and IJs that are inserted percutaneously are not suitable for home use because of the greater risk for infection. Complications relating to occlusions, that would be fibrin sheath, pinch-off syndrome, and central venous thrombosis. So fibrin sheath is the formation at the distal catheter tip. It often presents as a withdrawal occlusion. So catheters, they remain functional for infusion. However, blood cannot be aspirated from the lumen. So physiologically, the fibrin acts as a one-way valve. The negative pressure that's used to aspirate the blood causes the fibrin to be pulled over the catheter tip and prevents blood aspiration. Pinch-off syndrome, it occurs when the catheter is being compressed between the first rib and the clavicle, which causes intermittent compression and pinching and leading to intermittent occlusion of the infusion and aspiration. It's often relieved just by changing the position of the patient. Typically, raising or lowering the arm can relieve the occlusion of the catheter, but the catheter may need to be repositioned or even replaced if it keeps happening. Central venous thrombosis, it typically prevents as the inability to infuse and the inability to aspirate without resistance. So symptoms are going to be swelling of the arm, shoulder, or neck, pain in the limb, jaw, or ear, and then a dilated collateral veins over the arm, neck, or chest. Those are the hallmark symptoms. Here are mechanical complications and their associated treatments. So pneumothorax, it can actually occur during line placement, and it's when air gets into the chest cavity and the lung collapses and it causes dyspnea or difficulty breathing. Sometimes pneumothorax, they resolve spontaneously, but other times you need to place a chest tube. For air embolisms, they can occur if the line disconnects during infusion and then like a deep inspiration occurs. It can cause death, so it's a very serious complication, and then treatment with hyperbaric oxygen has been effective. For thrombosis or any kind of other catheter occlusion, it could be a blood clot or other material that blocks the catheter, which is a little bit more common in PPN, and then treatment would be warfarin therapy or catheter removal. Continuing with mechanical complications and treatment, we have a catheter obstruction, so if a pump failure or if there's a kink in the catheter, it leads to a blocked catheter. Cathflow activase or alteplase is the only FDA-approved medication for correcting a catheter occlusion. So a dose of 2 milliliters or 110% of the volume of the catheter lumen, if it's less than 2 milliliters, is placed in the catheter lumen, and then the alteplase, it catalyzes the conversion of clot-bound plasminogen to plasmin, and it initiates fibrinolysis, so breaking up that fibrin. Pulmonary embolism is a blood clot in the lungs, and then we want to treat with prophylactic warfarin therapy and then routine EKG and echo. In summary, the potential for complications is very high if a patient is not managed properly. So you can have general complications, and those would be glucose intolerance, fluid and electrolyte imbalances, overfeeding or underfeeding. We can have catheter occlusions, catheter-related infections, which leads to sepsis. And then for long-term home care, we could have fatty liver infiltration, cholestasis, metabolic bone disease, and then even some psychosocial concerns. And then we're going to talk more about these long-term home care situations in the next module, which is home nutrition support.